Welcome and good morning. Today is Wednesday, March 4th. I hereby call the Insurance Subcommittee to order. Members, don't forget to sign in. Madam Clerk, please open the roll. Madam Clerk, please announce the roll.
Chair Lady, you have 7 members present. You have a quorum.
Thank you. Before we get started, are there any personal orders? Chairman Kumar, you're recognized.
Thank you, Madam Chair. We have the Tennessee chapter of the American Academy of Pediatrics, and they are here in full force and ready to be involved in the legislative process. Welcome.
And I have an announcement. I have 2 good friends from Hamilton County here, Karen and Kevin Davenport. Can we give them a warm welcome? Today we have 18 bills on our calendar, but we're going to start with some housekeeping. Item number 16, House Bill 1646 by Representative Freeman has been taken off notice. Item number 9, House Bill 1848 by Representative Butler has been taken off notice. Item number 10, House Bill 2331 by Representative Butler has been taken off notice. Item number 11, House Bill 2332 by Representative Butler has been taken off notice. And item number 12, House Bill 2333 by Representative Butler has been taken off notice. Next, we are taking up item number 18 out of order. And it's House Bill 1959 by Representative Scarborough. Do I have a motion and second?
Motion.
We have a proper motion and second. Chairman Scarborough, do you have an amendment?
I do, ma'am.
What is the drafting code?
Let's see. Madam Chair, 013168.
We have a proper motion and a second on the amendment. We're going to go ahead and put this amendment on the bill because it makes the bill. Do I have a proper motion second?
Motion.
We are now voting on the amendment. All those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. The amendment is on the bill. Chairman, you can explain your bill as amended.
Thank you, Madam Chair. HB 1959 is as amended, is a licensure conflict of interest reform under Title 63 of the Pharmacy Practice Act. This bill does one core thing. Beginning in January 1 of 2028, some same corporate structure cannot both control a pharmacy and control a pharmacy benefit manager or a covered insurer in Tennessee. It separates financial control from patient care decision-making. The General Assembly has recognized in the findings that vertical consolidation creates conflicts of interest where the entity setting in reimbursement rules cannot own the pharmacy being reimbursed. I'm going to tell you what the bill does not do. It does not regulate prices. It does not redesign insurance. It does not eliminate mail order. It does not prohibit specialty pharmacy. It does not interfere with employer self-funded plans. It does not apply to TRICARE, and it does not apply to hospitals operating hospital pharmacies. What it does establish is prospective licensure standards, prospective license standard. If you want to hold a Tennessee pharmacy license, you cannot simultaneously own or control a PBM and a covered entity. There's a delayed effective date. There's a structured divestiture. There's a delayed effective date. There is a structured divestiture window. This is narrow, it's prospective, and it's enforceable through civil penalties, not criminal. It is about structural integrity in our pharmacy and our marketplace. And I'll respectfully stand by for questions.
Thank you for that explanation. We do have a lot of testimony, so without objection, I'm going to go out of session. First, we will start with Special Operations Association of America, Donald Franklin. CVS Minute Clinic, Michelle Lawson. Lumerica Health Services Specialty Pharmacy, Ben Heiser. CVS Health, Adam Rogers. PCMA, Michael Power. Connie Sharp Elliott. Natalie Elliott Handy.
That's the name that they put on there, but they represented.
Thank you. If everyone will start with you furthest from the right, state your name and who you're with, and you have 3 minutes.
Good morning, Chair Lady and members of the committee. My name is Don Franklin. I'm the Legislative Director for the Special Operations Association of America. Thank you so much for your time today and for your consideration of our testimony. Regarding Bill HB 1959, we do appreciate the amendment offered. We still do have deep concerns regarding the utility of that amendment and how it applies to TRICARE and our members. We look forward to working with the committee moving forward to find more language. Further considerations actually have to do with the community care network, which is operated through the Department of Veterans Affairs, which holds a nationwide contract with a PBM known as OptumRx. I will be very upfront. I'm not a PBM expert. I'm learning as much as I can, as quickly as I can. And I've been pinging some of our legislative counsel up at Big VA in DC and some other folks to try to get some language of full scope of regulation and statute that guard the federal pathways for our members. But regarding community care within the state of Tennessee, it's the only federal pathway available to our members, right? Particularly OBGYN services is not carried under the umbrella of Department of Veterans Affairs for veterans benefits. Those all go to the community care network, which will fill prescriptions and also provide services through a PBM, which is currently OptumRx. Further considerations, any type of emergency healthcare or urgent healthcare situation, say a veteran has a pretty drastic car wreck, they're going to go to the ER for their benefits to cover them. Those benefits and prescriptions are going to go through that PBM contract through the hospitals. For any type of community care specialty services, those types of services and those prescriptions will have to be contracted through that same federal contract with the PBM. That is some major concerns that we hope can be addressed and included within future amendments. Thank you.
Thank you. We're just going to go down the line and let everyone speak their 3 minutes, please.
Thank you. Good morning, Madam Chair, members of the committee. My name is Michael Power, and I'm with the Pharmaceutical Care Management Association. We are the national trade organization who represents the pharmacy benefit managers. We are here today respectfully in opposition to House Bill 1959. We understand that the intent of this bill is to get at our members' business model, if you will. But unfortunately, as it is written, even with the amendment, it will put Tennessee patients at risk. As written and amended, 1959 will result in retail, mail, and specialty pharmacies closing across the state here in Tennessee, which will limit access to your constituents, veterans, and patients with chronic healthcare conditions. The legislation does not put PBMs out of business in Tennessee, plain and simple, but it could result in several pharmacies, well over 100 and maybe as many as 600 pharmacies in the state closing. So for those reasons, we request you to oppose House Bill 1959.
Good morning, Madam Chair and members of the committee. My name is Natalie Elliott Handy, and I want to share a bit about my family because I'm here representing my mother, Connie Elliott Sharp, or Sharp Elliott, I apologize. I was born and raised in East Tennessee in a small town you may know today as Rocky Top. When I was growing up, though, it was still Lake City, a coal town where my grandparents owned a local hardware store for more than 50 years. My mother, Connie Elliott, lives with early onset Parkinson's disease. Her symptoms began when she was 48, and she was formally diagnosed at 52. Today, at age 71, she has lived with Parkinson's for more than 23 years. When our father, her high school sweetheart and husband of 40 years, died of a massive heart attack on July 4th, 2011, at the age of 58, my sisters and I became her caregivers. Let me explain how we first learned about specialty pharmacy and what it actually does. In July of 2023, because of a returned piece of mail, my mother was mistakenly recorded as deceased in the insurance system. My dad's pension stopped, her insurance was canceled, and the medication she depends on could not be approved. At that moment, we only knew one thing: the refill would not go through. The pension company recommended we pay and wait for reimbursement. Her medication costs more than $7,000 for 28 days. When we called specialty pharmacy, we expected the conversation to end there. The insurance was inactive, so the prescription could not be processed. Instead, they listened and then they helped. You see, they understood the urgency and sent the medication anyway while the insurance issue was being resolved. That was the moment I realized we were dealing with something very different than a traditional pharmacy relationship. To understand why this matters, it helps to understand how this treatment works. What my mother receives is not simply a prescription. She receives a treatment. Her medication arrives in a refrigerated cartridge shipped overnight. Each day, a cartridge is placed into a pump that she wears around her neck for 16 hours. That pump continuously delivers medication through a stoma directly into her stomach. Without that system, she would require 16 pills a day, taken every 2 hours with absolute precision. In Parkinson's care, timing is treatment. While medication is delayed or inconsistent, her body can lose the ability to move, speak, or function. The anxiety or fear of this onset alone moves our mom to a manic state, resulting in a trip to the emergency room and at times hospitalization. For our family, these cartridges are not simply medicine, they are life. They are her life. But the medication itself is only part of the system. Every shipment includes the components required to operate the pump: connectors, tubing, batteries, syringes,
Your 3 minutes is up. Are you almost finished?
I am almost finished if I
Okay.
can fix this.
Thank you.
It is important to understand my family are small business owners. I am a small business owner myself. And while I believe in that opportunity for small businesses because what it's afforded me and what my parents and my grandparents taught me, I also know that my local pharmacy, who is the corner drug, I went to school with her because she's a pharmacist and her dad was a pharmacist and his dad was a pharmacist, but they do not have the expertise that specialty pharmacy can offer to my mom, which would negatively impact her care. And I absolutely urge you to find an alternative solution to a bill that would allow my mom not to negatively be impacted by this legislation. Thank you.
Thank you.
Madam Chairman, my name is Michelle Lawson. I am a nurse practitioner with CVS Minute Clinic in Cleveland, Tennessee. I live in Cleveland, Tennessee. I'm a constituent of Mr. Raper. I was able to meet with representatives several times in the last couple weeks. And during my 4 years with Minute Clinic, I've been able to build relationships with the families in my community. One relationship I'd like to share with you is of a father, I'll call him Andrew, and his 10-year-old son, I'll call him David. Andrew brought David into my clinic one evening thinking that David had COVID. After talking with Andrew and assessing David, his symptoms were very concerning. I was able to complete additional tests while they were in clinic, and David actually had a very serious, undiagnosed chronic condition. I was able to call the local children's hospital. I sent his labs over, and they were ready for David when he arrived. David spent several days in the ICU recovering, and I'm happy to say now he's at home and he's thriving. A couple of days later, Andrew returned to the pharmacy to pick up David's medication. I was talking with him to see how David was doing, and he shared how much our support had meant to him and his family. He also was appreciative of the pharmacy staff. They explained all of his new medication, but also made sure that his family had everything they needed at home to continue his care at home. The compassion between the pharmacy and the clinic had an enormous impact on this family. And it just shows that what we do every day in our community matters. And this is just one example of what our clinics do every day in our community. This bill would close CVS pharmacies, and with it, 25 minute clinics, 72 nurse practitioner and provider associates who support the stores would also be shut down. Nearly 94,000 Tennesseans rely on our clinic for over 137,000 visits last year. Removing this infrastructure from a state that's already suffering severe provider shortages would worsen delays, reduce access to care, and harm the families who depend on us for primary care, preventative care. They rely on us to be affordable. They rely on us to be available evenings and weekends. I respectfully urge you to vote no on this bill. I understand I may stand to lose my job if this bill passes, but more importantly, my patients, my community, they're the ones that are going to suffer from this. Thank you.
Thank you.
Good morning, Madam Chair and distinguished members of the committee. My name is Ben Heiser. I'm CEO of Lumicera Health Services, a specialty pharmacy and a licensed Tennessee pharmacist. Lumicera Health Services was established in 2014 by Navitus Health Solutions, a PBM, at the request of our clients, looking to strengthen patient access to specialty medications in a way that aligns Navitus's model of transparency in the healthcare space. The result was the creation of Lumicera Health Services, the only cost-plus specialty pharmacy in the nation, and we believe that's still the case today. By cost plus, I mean we charge exactly what we paid for the medication. There's no markup. So if we bought a medication for $7,000, we charge $7,000 to the plan sponsor plus a set fee for the services that we provide that is known and fixed. While Lumicera is affiliated with Navitus, a pass-through transparent PBM, does not require their clients to use Lumicera Health Services for their specialty pharmacy needs. As a result, only about 30% of Navitus specialty patient volume actually uses Lumicera Health Services for their specialty pharmacy provider. This framework ensures that Lumicera model is centered around high-touch, patient-first approach that delivers the highest standards of specialty pharmacy care and boils down to transparency and choice. We believe House Bill 1959 will create unintended and significant disruptions. The bill threatens patient access to essential therapies that rely on timely specialty medications that are quite complex. Independent and community pharmacies typically do not have the same level of experience in efficiently helping to lower patient out-of-pocket costs through manufacturer programs, foundations, and the partnerships that Lumicera has gained over the years. As a result, many patients could face higher out-of-pocket costs, failure to start therapy due to high copay, and reduced access to treatment coordination and increased safety risks. Lumicera serves more than 30 clients, 1,300 patients right here in the state of Tennessee, 29 of whom are taking medications for oncology. House Bill 1959 aims to regulate the ownership of control of pharmacies by pharmacy benefit managers. However, the broad language captures far more than those vertically integrated PBM and specialty pharmacies who are using their relationship to their advantage and limiting patient choice. Our plan sponsors deserve choice and transparency. Instead of banning a business model or refusing to license a pharmacy because it shares a common ownership with a PBM, we need to focus on increasing competition and enhance patient choice, such as PBMs cannot force a plan sponsor to use an affiliated pharmacy. PBMs must disclose ownership or relationships with other entities. PBMs cannot punish or financially ban a plan sponsor from using a specific pharmacy. Forcing a pharmacy
I'm
closure.
sorry to interrupt you, but your time is up.
Can I finish to the very end? Thank you.
Okay.
Madam Chair and distinguished community members, I have many, many more things I could go through as to why we feel very strongly that this should boil down to transparency and choice. I would ask that you oppose this legislation because this bill targets the very pharmacies that are trying to actually make change in the industry by allowing choice despite our ownership model and giving patient choice and transparency. Thank you for your time.
Thank you.
Madam Chair, members of the committee, thank you for your time. My name is Adam Rogers. I am a pharmacist here in the state of Tennessee. I'm a lifelong Tennessee resident. I'm a graduate of University of Tennessee, Knoxville, University of Tennessee Health Science Center in Memphis. I'm also a district leader and community pharmacist with CVS Health. So my background started when I was at a very young age. In 7th grade, I realized I wanted to be a pharmacist. That came from when my dad was very ill. And I saw him taking a lot of medications, and I was not understanding what was happening. And the only person that helped me understand what was going on was a community pharmacist. Since that time, that's just really shaped my compassion for my career, and it wants me to make sure that I have that ability to reassure clarity to others. And for the past 15 years, I spent my career at CVS Health. So this proposed legislation would force the closure of 134 pharmacies locations, cutting off access to care to the more than 1.5 million Tennesseans, jeopardizing thousands of pharmacy jobs, including 428 pharmacists, many of who are sitting right here in this room behind me. And that would, by jeopardizing those jobs, it would cut off essential medications, immunizations, and trusted support throughout our communities in Tennessee every day. Our pharmacists are woven in our communities we serve. They don't go to see the CVS. They go to see the Adams. They go to see the Ashleys. They go to see that pharmacist that's there at that store. Those pharmacists are their community pharmacists. We're open nights, weekends. We're very convenient. We're reliable. We're open times that other places can't be open. And if all these locations close, it's really going to put a strain on the health system. And there's not enough infrastructure to absorb the amount of prescriptions that would be coming out at that time with the immediate closure. We also fear that this bill would worsen wait times, deepen gaps in already underserved areas, and dismantle pharmacy services that are vital to our community. I understand that there's a lot of concern with this bill. I know a lot of community pharmacists and own independent pharmacies. I understand their frustrations with the bill. But the one thing I could say in this situation, this bill does nothing to do anything to stop the spreading, the price spreading, or the steering in this. It does not impact how the PBM would operate in the state. It would just result in a lot of pharmacies and a lot of pharmacists and a lot of Tennesseans losing their jobs. So based on that, I respectfully urge you and the committee members to vote no for this. Just to be clear, again, there's a lot of folks that will lose their job in this room right now, but far more important to us are the patients that we serve. And what we went to pharmacy school to do is take care of those folks in Tennessee, and we respectfully ask for your permission to keep doing that. Thank you.
Thank you. Members, do we have questions for our speakers? Does anyone have any questions? Thank you.
Kumar does.
Oh, I'm sorry, Chairman Kumar, you're recognized.
Thank you. Well, ladies and gentlemen, thank you for being here. It is good to have your input, and it's very crucial to us that we understand. It's also important to our patients and our citizens. They also understand that what your point of view on this matter is, and that we are sharing this information and learning from each other. Is that Mr. Powers? Okay. Kindly tell me, do you not see any conflict of interest in the business model that you have?
So if we're talking specifically about, oh, sorry, Madam Chair. Sorry. Thank you. If we're talking specifically about vertical integration of businesses, then I think you're in a unique position in the government to not pick winners and losers, because there are other players in the supply chain, so particularly in the healthcare space, the wholesalers, hospital systems that are also vertically integrated. And so if there's a problem with the business model, then I think we need to be looking at all entities and not just one.
Well, it will be good to hear about the one we are considering today under this bill.
Oops, sorry, Madam Chair.
You're recognized.
This committee, this legislature has heavily regulated the PBM space for the last decade or so, including some legislation that passed recently that creates an external examinations process that the department is going through now. And so I think those exams are happening. This industry with mergers and acquisitions were heavily scrutinized by, why am I drawing a blank right now? The U.S. Department of Trade and all sorts of other regular entities that need to review these mergers and acquisitions, and they were approved.
Chairman Kumar?
Well, coming back to the point, is there a conflict of interest in this model? It's not that others are doing it and there are other models that are vertically integrated. But in your situation, clearly, do you not see a conflict of interest that the PBM owns half of the pharmacies, other pharmacies are not owned by PBM? So it's sorry for the well, no, I don't apologize for it, but you can clearly say that these are my children and these are my stepchildren. And there is a difference, as kind a parent as you can be, still, there is a difference that children get treated, or there are instances where children do get treated more sweetly than stepchildren. That's a cliche, but it applies in a way. And I was just thinking that if you would realize or acknowledge or halfway agree that, yes, a conflict of interest can arise, then let us talk solutions. Is there a way to create a business model in which there is a distance between your PBM, Caremark, and the pharmacies that you own so that people have an appearance of, or the fact that they feel things are at a fair level and on an even ground?
Madam Chair.
You're recognized.
So again, I'll defer to the examinations process that's been established by this state. And further, I think it would be important for this committee and this state to fully understand the impact of all the players in the system to look at reform in the pharmacy service administrative space. Look at the wholesalers. I think there was a group that spoke last week before the Senate committee, Tennessee Oncology, which is owned by One Oncology, which is owned by Censura, which owns a PSAO that negotiates with a PBM on the price that we reimburse them for the goods that they charge them for to go on their shelves. And so I think for this committee to have a better understanding of the vertical integration that occurs in this space in its entirety in the ecosystem, we need to cast a wider net of what we're looking at other than just one entity. We're just squeezing the balloon right now.
You have aptly argued your case to the public, and you've created a sense of concern and panic that pharmacies are going to close and so many people are going to lose their jobs and so on. Along that journey, along that way, as you think about it, again, I ask you, do you think of a solution where things can be reorganized in such a way that patients continue to be served and jobs continue to be kept secure? There has to be a way that a distance can be created so that services continue. Have you not considered that as a possibility at all?
So I'm sorry,
You're
Madam Chair.
recognized.
I'm just in government affairs. I'm not, I don't work for a representative of the company. And so I can't speak to what their business model could or could not look like in the future.
It's your company, isn't it?
You're recognized.
The Pharmaceutical Care Management Association is the trade organization representing the businesses.
Oh, I see. The second thing that it occurs to me that specialty pharmacies, it's a very important piece, a very important service. It's critical. And again, why do specialty pharmacies have to be owned by a PBM? They are freestanding. They can be paid by the insurer, just like if I was a physician in private practice, patient came to me, I'm on the insurance's list. With a contract with them, I give the service to the patient, I send a bill, and the insurer pays me. Why can't specialty pharmacies function on that model?
You're recognized.
They don't have to be. They just, today many are, but there are many that exist around the country that are not. But you do have a number that are headquartered here in the state that would be impacted directly by this legislation.
Okay, so that's reassuring to say that specialty pharmacies do not have to be owned by a PBM.
You're recognized.
They don't.
Okay, but that's very reassuring. That really is, because that has been put up as a major point that will create problems. Again, I thank you for coming, and I will ask the same question at large to all of you. Do you have a solution? Do you think the things can be organized in such a way that all pharmacies are treated equally, the ones that are owned by one company and the ones that are not, and yet they're serving both groups of them. And is there a solution orientation in our thinking? I invite you.
You're recognized.
Thank you for the opportunity. I do think that there is an opportunity to look at how something like this, which broadly, I agree with the approach that you're taking. Again, I think it's potentially extending just a bit too far. And using an example right here in the state as to, I think it really boils down to transparency and choice. So as I mentioned, our relationship with Navitus Health Solutions, we provided PBM services right here for Vanderbilt University Medical Center for a number of years. We did not require Vanderbilt to use Lumicera Health Services for specialty pharmacy needs. They have an outstanding specialty pharmacy right here. Others that we support within the state, City of Chattanooga, Knox County, just to name a few, made the decision that they wanted the transparency and the low net cost that Lumicera could bring to the marketplace for their benefits and chose to use Lumicera. So it really drove the choice to the individual plan sponsor. And I think rather than just saying, if you're vertically somehow linked, you can't do business in this state. There's other regulations that we've seen in other states around any willing provider networks, anti-steering to owned pharmacies and those types of things that can accomplish a similar goal and not just completely shut down a business of which, again, 70% of our business has nothing to do with our parent organization. So in that situation, should an employer or a government entity want to work with Lumicera, because again, we are the only cost plus specialty pharmacy in the nation, we wouldn't have the ability to support them because we couldn't be licensed in this state. Again, it would have nothing to do with our ownership around Navitus. That's where I'm saying I think it's just a little bit more broad than it needs to be. I hope that is something that you could consider.
Thank you. You have the seeds for a solution. It just has to be nurtured and grow, and maybe the subject of discussions next year. Again, I appeal to you that scaring the public about loss of their services, especially the patients, some of them, you know that, and I know that as a physician, some of them really have serious illnesses. There is stress to that, there are financial pressures to that, and there are families that are torn apart by it. Adding this stress to them, they're going to lose their medication services and so on. That is very strong. And I think we should be very careful in taking that radical a step. Sure, pharmacy services from CVS and other are very, very important to the state of Tennessee. Yet, the state of Tennessee and the amount of revenue you get from us is also very important to you. But then again, let's leave that aside and keep in mind the citizens that we serve. And I think we can all agree on that. Thank you very much. Thank you, Mary.
Thank you. Representative Hakeem, you're recognized.
Thank you very much, Madam Chair. I guess I'll use that term, feel like between a rock and a hard place. There's only so much knowledge and understanding I have on the subject. I've attempted to really dive into it. I've heard from people on both sides of the issue, professionals. And I think I have to distill it and take it down to where not only myself, but maybe constituents from across the state can understand. I see a move of this nature as not being in the best interest of the average citizen. And, I see this potentially as shifting money from one group to another group. But the citizens are, in a sense, caught in the middle. And I felt, maybe I'm wrong, my role is not to, I guess, pick the winners, but what is in the best interest of the citizens of this state. And I just want to let people know where I am on the subject. And I will not be voting to support this legislation. Thank you.
Thank you. Anyone else? Okay, seeing none, thank you for your testimony. We do have one more person from CVS Specialty, Aaron Sago. Thank you. Please state your name and who you're with for the record, and you have 3 minutes.
Thank you, Madam Chair. I get the pick of chairs, so thank you for that as well. Again, my name is Erin Sego. I am a specialty pharmacist here in Tennessee. I've been serving Tennesseans for nearly 20 years in the state. And what continues to drive me really is being the first point of support for these patients that are onboarding serious disease states, medications that are complex, and often treatments that are life-altering. We heard already from family of one of those patients. So really, specialty matters, and I know there's a lot of talk about specialty in regards to this bill, but these medications require special handling, strict temperature control, intensive clinical support. So they are special, and specialty pharmacy is important for that reason. Our teams talk with these patients day in, day out, how to administer these medications safely, monitor for side effects, coordinate follow-up, and really stay on track with their treatment for these life-threatening conditions. Just another example of what we do day in, day out. Recently we supported an oncology patient right here in the Nashville area, urgently needed a medication that was very difficult to find in order to be released from the hospital and go home. This required coordination across multiple sites, multiple nurses, multiple facilities. We were able to track down the medication in Memphis, which is coincidentally where I work out of. We're able to same day courier that medication here. Within 3 hours, that patient was able to get that medication and go home safely. So really being able to bring those right people together in moments of critical need is where specialty is important and so essential for our patients. This bill would shut down specialty services in Tennessee as well. That's about 36,000 Tennesseans with complex conditions, and really hinder their access to life-saving medications and the clinical expertise needed to use them safely. Really, it dismantles infrastructure. I know there were comments about, can this be done on an independent basis? And yes, there are independent specialty pharmacies, but the infrastructure that CVS has really makes timely and specialized care possible. And it leaves thousands of patients potentially without a viable way to receive those medications. Again, I respectfully urge you to vote no on this bill. If it does pass, obviously there are likely to be site closures, including my own. So, but the concern is for the patients and really their access to care and continued access. Thank you.
Thank you. Any questions? Chairman Kumar?
Well, thank you for coming, and we appreciate your comments. I thought during the discussion previously, we were able to establish the fact that specialty pharmacies do not have to be owned by a PBM. And I appreciate really the timeliness of your work, the sincerity of your work, and the supply of your very sophisticated service. I appreciate that. But at the same time, an ownership by a particular party is not necessary. You can, specialty pharmacies, as we saw, do work on an independent basis. And again, let us not scare people. Let us not, please. You know those people very well. You know they have serious illnesses. They have very serious concerns and worries. To scare them by saying that you're going to just close shop let's not do that, because there are alternatives available. Let us continue to provide them the service, and let's find a solution. I invite people to come up with a solution, and or legislature will work to have a solution of our own, and that's what we are working towards, to make things equitable and equal and sensible. But once again, I urge you not to scare people that they're not going to have their service, despite the fact that we respect your service. Thank you very much. Thank you, Madam Chair.
Thank you, Chairman Kumar. Do you have any response?
My response is that yes, infrastructure is incredibly important, especially for specialty pharmacy. The amount that goes into, again, couriering medication from one side of the state to another, it's very difficult to do on an independent basis, right? There is a ton of infrastructure, 24-hour services required, just a lot that goes into it. And, being part of a partnership with CVS does allow us to do those things and do them timely for these patients that have critical need.
Thank you. Do we have any further questions from the committee? Thank you very much for your testimony.
Thank you, Madam Chair.
Next, we will call up Anthony Pudlow with the Tennessee Pharmacists Association, Jessica Balladad, Alex Mexner, and Ralph Weber. Okay, we'll start with you, Mr. Pudlow. Just please tell us who you are and who you're with.
Yes, good morning, everyone. Good morning, Chairman Hilton Haynes, members of the committee. My name is Anthony Pudlow. I'm a pharmacist and the CEO of the Tennessee Pharmacists Association, of which represents 2,500 pharmacists, pharmacy technicians, and students of the profession across every practice setting in the state. I'm here in support of House Bill 1959. As many of you know, pharmacists are some of the most accessible healthcare providers in our state. It's even been cited that patients will see their local pharmacy twice as often as they see their primary care provider. But since 2017, when we started seeing major consolidations in the insurance industry, including CVS, Aetna, and Caremark, Cigna and Express Scripts, United Health, and Optum, we have seen a tightening of the PBM issues in our country, whether it's pricing or patient access. And I think it's no surprise in that same time frame that we've seen close to 600 pharmacies close in the state of Tennessee. That includes 284 independently owned pharmacies, as well as 314 chain pharmacies in the state. To our calculation, roughly about a third of pharmacies have closed in those 9 years. And those pharmacies that have survived have had to have reduced hours, less 24-hour options, less overlap for pharmacist coverage that are immediately having an impact on how somebody from the public sees and views their local pharmacists. And this is a system-wide issue. This is not just an independent pharmacy issue. Hospital pharmacists are saying the same thing as our other chain pharmacists, like those that work at Walgreens and Publix. And honestly, these closures have only accelerated despite some of the best efforts of this committee and the entire General Assembly. And I would even just say that these consolidations have also not held up to the promises of lowering healthcare costs. I think we can look at data from the Kaiser Family Foundation and look at the increasing number of healthcare premiums over that same amount of time. And at the same time, these PBM practices, whether it's steering patients to their own affiliated pharmacies, restrictive formularies, punitive audits, have really limited competition. They've confused patients and harmed those non-affiliated pharmacies. I think it's also important, it's been somewhat referenced already, but there is data from the Tennessee Department of Commerce and Insurance with their authority to audit PBMs. And we have seen this self-dealing and lack of compliance with the current law, especially by those PBM affiliated or those vertically integrated PBMs. Whether it's CVS and Caremark being cited for paying their own affiliated pharmacies upwards of 16,000%. 16,000%. Like, grasp at. That's potentially a product that maybe one pharmacy, a non-affiliated pharmacy, is getting paid $50 and the other one getting paid closer to $10,000. Cigna and Express Scripts, they've been cited for spread pricing practices where they're actually, in the sample that the state had, withholding $30 million.
I'm sorry to interrupt you, but your time's up. Can you finish really quickly?
Yeah, I would just offer and say that we agree that it's time for the Board of Pharmacy to have the opportunity to regulate these practices, and we want to install that transparency and fair and meaningful competition and support this bill. Thank you.
Thank you. You're recognized.
Yeah. My name is Jessica Balladad. Thank you so much for allowing me to speak today. I'm here today as a 7-year breast cancer survivor. I was diagnosed with breast cancer at 33 years old, and at the time, I had no idea what I was about to face. 14 women had already been diagnosed before me in my family. So in truth, I had a pretty clear idea of what was coming. But what I didn't know was whether I could afford to stay alive and how complex our healthcare system is until I had no choice but to become immersed in it. During treatment, it was essential for me to manage the side effects of chemotherapy, and my local pharmacy in Clarksville, Tennessee, knows my history. They understand my medications, and they help navigate insurance issues that patients can't solve alone. That relationship matters because when you're managing a serious illness like breast cancer, like you're relying on whatever resources you can to kind of figure it out. I abstained from sweets while going through cancer. However, the local pharmacy I use always puts this little Andes mint in the bag. And that mint was and still is a piece of indulgence that adds that personal touch to the care that they provide. But the locally owned pharmacies that serve my community, like Clarksville, operate under reimbursement rules they do not control. PBMs, or what I have started calling predatory benefit managers, are threatening local pharmacies by controlling the reimbursement rules those pharmacies must operate under while also competing against them. They decide how much the pharmacies are paid, which pharmacies patients are allowed to use, and in some cases, even force patients towards pharmacies they own. Over time, that threat to survival of the locally owned pharmacies patients like me rely on. HB 1959 would ensure that pharmacies serving our communities can continue to compete on a fair playing field and provide the kind of personal care patients like me depend on, even if it's something as simple as a little Andes mint in the bag. Thank you.
Thank you. Do we have any questions from our members? Seeing none? No questions? Well, thank you both. Thank you for your testimony. We are now back in session. Representative Scarborough, you are recognized on your bill.
Thank you, Madam Chair. This bill is about structural clarity. When the entity that sets reimbursement rules also owns the pharmacy receiving those reimbursements, that's a structural conflict. This bill separates those roles prospectively. It preserves employer plans, it preserves TRICARE, it preserves hospital pharmacies, it preserves mail order and specialty pharmacies. It provides multi-year transition. It's narrow, it's perspective. It's enforceable through civil processes, includes due process protections. This is a licensure integrity bill under Title 63. Madam Chair, with that, I renew my motion.
Thank you. Do we have any questions from the members? Representative Freeman, you're recognized.
Thank you, Madam Chair. To the sponsor, I respect you immensely. I like what you're doing here. I've too have an issue with vertically integrated businesses. But the way this has been explained to me up until today was that we were not getting the best treatment and the best quality of care to the people of Tennessee. I've heard over and over from CVS and different pharmacies in my community that they are going to shut down. I've heard over and over from veterans that they are going to have a restriction in their ability to get coverage. And as I'm listening to the testimony, both for and against, this almost seems like it's more of a breakup of a monopoly as opposed to an increase in care. And is that your intent, or do you generally not believe that we're going to have an impact in pharmacy access? Because in my community, that is the access. And I don't see, we've seen whatever the number was, 350, 400 pharmacies shut across the state. I don't see pharmacies, chomping at the bit to come open up new pharmacies. So how do we think this backfill of access is going to be filled?
Representative Scarborough, you're recognized.
I thank my colleague for the input there, and I return the respect, my friend. Quite frankly, and I want to make this critical to the caregivers in the room today, your first frontline caregivers and those across this great state of Tennessee. I'm sorry that you feel like you're caught in the middle of this. Again, sometimes there's right decisions and wrong decisions, but a lot of times we're up here, the folks elected us to make the hard decisions. And this is something we have to change the structure to remove this conflict of interest. As far as access, quite frankly, I have a lot of confidence, not just in the people in the room, but in the state of Tennessee and innovative folks around the state who I think are very talented. Many are in this room today that can help fulfill that access. But under the current structure, you pointed out, nobody's rushing to open pharmacies up. And under the current structure, that's still not going to happen. But I appreciate the question.
Representative Freeman.
Yeah, thank you, Chairman. I guess can you address the breakup of the monopoly piece, because I feel like that this is the first time that angle of this has come out, both from the people that are for the bill and against. And is that your intent? And if so, let's have that conversation, and I could maybe get behind that.
Representative Scarborough.
I think that's what we're saying here, Representative. We're not saying you can't be a PBM, you can't be a pharmacy. You just can't own the PBM and the pharmacy. We have to break up that structure. It's a licensure bill, simple as that. And with that, I renew my motion.
Got it. Thank you.
Any other questions? Chairman Kumar.
I want to thank the sponsor for bringing this legislation. It is something very important, and it needs to be done. And thank you again.
Thank you. Okay, without any questions, we are ready to vote on House Bill 1959 as amended. Clerk, please open the vote. Has everyone voted? Does anyone wish to change the vote? Clerk, please announce the vote.
Madam Chair, you have 5 ayes, 2 nays.
Thank you. The ayes have it. House Bill 1959 goes to full insurance. We have item number 1, House Bill 2619 by Chairman Howe. We have a proper motion and second. Chairman, do you have an amendment?
I do, Madam Chair. That is 014046.
We have a proper motion and second. We are going to go ahead and vote on the amendment and put it on the bill. All those in favor signify by saying aye. Opposed? The ayes have it. The amendment's on the bill. Chairman, you're recognized on the bill.
Okay,
As amended.
if I could briefly explain what the amendment does, it just requires that health insurance companies who own any part of a health provider must disclose that to the patient, to the Department of Commerce and Insurance, and to the commission that's created by this legislation that I'm presenting today. That's what the amendment did. This is called, I call it the patient's first bill. Others have called it something else. But the bill is about fairness, and it's about transparency. It's about accountability. And as I was listening to the comments on the panel, it dawned on me what we're trying to do here is head off a monopoly, because that's where it's headed in the insurance industry now. And this patients deserve medical decisions that are made by qualified professionals, not artificial intelligence algorithms, because that is what's happening now. And the first thing it does is address the artificial intelligence. That's on page 12 of the bill. Insurance companies in this bill will not be allowed to use artificial intelligence only to deny or approve a claim. That's happening now. If you happen to watch some of the hearings in Congress in the last few weeks, one of the large insurance official with one of the large insurance companies explained to Congress how much they loved AI because it could deny a claim in 4 seconds. No medical oversight. They just let AI deny the claim. This bill says that you cannot do that, that a qualified healthcare provider must review that claim, no matter what AI does, either approve or disapprove. It must be reviewed by a medical professional. Technology is great. We all probably use AI. We use ChatGPT sometimes. It's good, but as I have discovered, and you have too, you have to review it because sometimes it doesn't say what you want it to say. So it prohibits sending a patient's medical information outside the United States for claim review. That is currently happening. One estimate says that 61% of all claims are sent outside the United States. I don't like that, and neither do my constituents. It's estimated that 81% of first-time claims are denied by AI. I was a victim of that, first-time claims, which was the genesis of this bill, by the way. It also creates independent oversight. The bill creates the Tennessee Commission of Insurance Review. That's on pages 4 through 8 of the bill. The commission will hear complaints, investigate complaints of wrongdoing, and the enforcement will be done through the Attorney General's office. And I believe the patients and providers will finally have a clear place to turn when disputes arise, especially when insurance companies are practicing medicine without a license, which I have experienced and some of you may have too. I've had many medical professionals, doctors, nurse practitioners tell me that the insurance companies definitely tell them what to do. That's practicing medicine without a license, folks. It addresses downcoding and underpayment on page 8 of the bill. Insurers cannot reduce payments by changing billing codes improperly. On page 9 of the bill, they must give a 60-day notice for contract changes. This is only fair to the provider. I have a large hospital in my district where they got a letter and overnight they were suddenly out of network. No negotiation. And that one letter put about, I'm estimating 8,000 people out of network to that hospital. Now they have to drive 45 miles to Chattanooga to get care in network. That's not right. It's not good for our constituents, and it's bad health care. That's what this bill does. It also ensures reimbursement equity. That's on page 15 of the bill. If 2 licensed providers perform the same service, they should not be paid differently. And so this bill says there will be equal service equity. They will get equal reimbursement for equal service. And finally, the ownership transparency page that was put on by the amendment that you passed earlier. And in closing, this bill does not eliminate innovation. It does not prevent insurers from managing costs. It simply ensures that decisions are fair, transparent, and accountable. And I appreciate those of this committee who have signed on to this bill, and I'd ask for a positive recommendation.
Thank you, Chairman, for that explanation. Representative Raper, you're recognized.
Thank you, Madam Chair. And I want to say, in my time in the legislature, I think this is one of the best bills that I've ever seen. I am so supportive of this. I encourage the public to look at this. Can you imagine good people with good reasoning, good medical backgrounds, and are currently acting, that they can even really provide any kind of input other than AI just makes a decision on it? I can't imagine. And they have justified reasons for not being accepted And it amazes me. So at this point, I think this is such a great bill for all the state of Tennessee. And I personally feel like that it's a bipartisan bill. And the reason why is this. All of the state of Tennessee, Democrat, Republican, any race, gender, everything is impacted by some of the things that Chairman Howe is addressing. So I think this is something for all citizens of the state of Tennessee, and I am tremendously backing you, Chairman Howe. I hope this passes. Thank you.
Thank you. Representative Scarborough, you're recognized.
I want to thank the sponsor for bringing the legislation. It's very timely and it's so important. Real quick question. Now, you may have mentioned it, sir, and I might have missed it. Does this include dental as well?
It does not. It does not address dental.
Okay, thank you.
That's all.
Any more comments or questions from the members? Okay. I think we are ready to vote on House Bill 2619 as amended. Clerk, please open the vote. Okay, clerk, please announce the vote.
Madam Chair, you have 7 ayes, 0 nays.
The ayes have it. House Bill 2619 goes to insurance full.
Thank you, Madam Chair
Thank you.
and committee. Thank you.
Next, we have item number 2, House Bill 1930 by Chairman Vaughn. We need to send someone to get him. Be just a minute. We're going to take a minute recess. We are now back in session. I do want to take a personal order and recognize my dear friend, Dr. Shannon Berger, the CEO of Simpa Community Cares. Let's make her welcome. Sorry. Okay, we are on item number 2, House Bill 1930 by Chairman Vaughn. We have a proper motion and second. And we do have an amendment.
Sorry, Madam Chair. I just discovered that sometimes the elevator doors close on the member elevator, or they don't close.
Oh.
And so they just halfway go. So pardon my tardiness, but I was almost victimized by an elevator.
That's quite all right.
The drafting code is 014294.
Okay. Do we have a motion and second on the amendment? Okay, we have a proper motion and second. This rewrites the bill, so we're going to go ahead and put this on. All those in favor signify by saying aye. Opposed? The ayes have it. The amendment is on the bill. Do you want to explain your bill?
Yes, ma'am. This deals with the topic of network adequacy within health plans and whether or not the health insurance maintains a network of appropriate participating providers and calls for a network examination, during which the network adequacy examination, the department will determine whether or not a material change to the provider network was reported timely and then make a series of specific network compliance determinations. And basically what we're trying to do is making sure that there are enough providers within a plan to make sure that the costs are appropriate and people are getting reimbursed at appropriate rates.
Okay, thank you for that explanation. We do have testimony, and so without objection, we're going to go out of session and hear from them. If you please will come up. Let's see.
Philip Hauser.
We have Philip Hauser and Bonnie Bruce. Just state your name and who you're with, and you've got 3 minutes each.
Madam Chairman, distinguished members of the committee, my name is Dr. Philip Hauser, and I'm speaking on behalf of the Tennessee Society of Anesthesiologists. There are 500 anesthesiologists and resident members, and I'm testifying in support of House Bill 1930. In 2023, the General Assembly unanimously passed a network adequacy bill by Representative Vaughn, which strengthened the network adequacy requirements for health insurance plans in Tennessee to ensure citizens access to the covered health benefits. One provision of the bill required carriers to report to the Department of Commerce and Insurance within 15 days any material change to their network. In the first couple of months of 2024, a health insurer dropped 3 private anesthesia groups providing care in hospitals, ambulatory surgery centers, and dental offices in the Chattanooga area, Knoxville area, Powell, Memphis, and Nashville areas. The Tennessee Society of Anesthesiologists sought to file a complaint against the network adequacy of the insurer to the Department of Commerce and Insurance. But first, we had to find out how, because the commissioner had never adopted rules to implement this law, and we were the first to file a complaint. While the DCI worked with the TSA to walk us through the process, they asked questions of both sides. We found that they were unaware of the health insurer's decision to drop over 758 clinicians in one specialty, that they lacked the authority to demand adequate documentation from the insurer, and there was very little transparency in the ultimate result of the complaint. To date, we still do not know if the DCI found the health insurer failed to properly notify the commission, if they ordered a corrective action on the insurer, or if the insurer was fined for its noncompliance. More importantly, the general public has no transparency on whether the insurers of Tennessee are complying with the new law and whether the state is performing its proper oversight and enforcement so that when they need it, the citizens of Tennessee will have access to covered health benefits their insurance is supposed to provide.
Thank you. Thank you.
Madam Chair, members of the committee, my name is Bonnie Bruce, and I am with the U.S. Anesthesia Partners, and I am here supporting House Bill 1930. While there are 2 representatives sitting at the table testifying who represent anesthesia, I want to be clear that this bill is a benefit for the patients of covered Tennessee regulated health insurance plans. And it is a benefit for all medical subspecialties and hospitals in Tennessee because it grants enhanced authority to the Department of Commerce and Insurance and regulatory clarity for the carriers. This bill does address a few gaps in the implementation of Public Chapter 352 by granting the DCI more authority to inspect and to collect documents while creating a clear roadmap for examinations of health plans with required decisions to be made by the DCI with specific and reasonable deadlines. It further enhances the network standards by requiring access to specialty hospitals like oncology and pediatrics if available in a geographic area, and requires that for facility-based providers, adequacy must be determined within that facility so that the patients have access to all the specialty care they need for surgical or emergent issues. The bill does allow for flexibility for carriers, exempting them from network adequacy standards if there are no available clinicians from after the carrier makes an effort to contract. And most importantly, the bill provides transparency by requiring disclosure on both the DCI and the carrier's website of ongoing examinations, and requires DCI to publish on their website the results of those examinations and the penalties associated with them. It further requires the DCI to report back annually to y'all so that you know what levels of coverage there are in our Tennessee regulated insurance plans. The General Assembly has seen fit to ensure that healthcare coverage in Tennessee equals healthcare coverage access, and we are supportive of those efforts.
Thank you. Do we have any questions from our members? Seeing none, we are back in session. Do you have any other words, Chairman
Oh, I
Bond?
couldn't follow that up, Madam Chair.
Okay. Questions for members for Chairman Vaughn? Seeing none, we are ready to vote on House Bill 1930 as amended. Clerk, please open the vote. Has everyone voted? Does anyone wish to change their vote? Madam Clerk, please announce the vote.
Madam Chair, you have 7 ayes, 0 nays.
Thank you. The ayes have it. House Bill 1930 goes to full insurance.
Thank you, Madam Chair and Committee, and I appreciate your indulgence over my tardiness with the aggressive elevator.
Thank you. Item number 3, House Bill 1756 by Chairman Rudder has been rolled to the Hill. Item number 4, House Bill 2162 by Chairman Rudder has been rolled to the Hill. Item number 5, House Bill 1826 by Chairman Eldridge has been rolled to the Hill. Item number 6 is House Bill 2243 by Chairman Martin. We have a proper motion and second. Chairman, do you have an amendment?
I do, yes, Chair Laney, 014409.
We have a motion and second. It does rewrite the bill, so let's go ahead and vote on that amendment. All those in favor signify by saying aye. Aye. Opposed? The ayes have it. Chairman, you're recognized on your bill as amended.
Thank you, Madam Chair and Committee. What this bill is a straightforward provider bill to support our state's pediatricians and small clinics across Tennessee. What it does is updates how quality metrics are calculated to prevent our doctors from facing unintended consequences for circumstances outside the clinical control. So the current problem, the federal guidelines have shifted a little bit. The federal government recently changed their guidance for pediatricians, removing certain mandates for certain pediatric metrics and shifting them to individualized choice. The contract lag for our state's insurance contracts haven't caught up with the federal guidelines just yet. So right now, if a patient falls into the new exempt category, the MCO system automatically dings the doctor's performance score. The fix just adjusts the formula. If a patient opts out, the MCO simply removes the patient from the doctor's quality score denominator. And with that, I do have an individual for testimony, if you so allow.
Okay, I think we will go out of session and hear from him. Mr. Andrew Schoenecker. Am I saying that right?
I think so.
I'm sorry, I don't know if I pronounced your name correctly.
That's all right. You could call me Drew Schoenecker. Yeah.
Okay, thank you.
Madam
I'm
Chair.
sorry.
No
Just
worries.
state your name and who you're with for the record.
I'm Drew Schoenecker and just a private citizen here in the state of Tennessee.
Okay, thank you. You have 3 minutes.
All right. Thank you, Madam Chair, members of the committee. Thank you for the opportunity to speak today. For the record, my name is Drew Schoenecker, and I'm here in strong support of the SHIELD Act. I had the privilege of serving as the primary technical architect on this legislation alongside Representative Martin and Chairman Watson in the Senate. The purpose of this bill is straightforward. It ensures that our pediatricians are not financially penalized simply for treating families who choose to follow new federal guidance. Recently, the CDC reclassified 6 childhood vaccines to shared clinical decision-making, making them an individualized choice. In response, CMS removed these vaccines from mandatory quality reporting, officially instructing states to stop tying provider revenue to vaccine rates. The federal government recognizes doctors shouldn't lose income over a medical decision they don't control. While the federal intent is clear, without adjusting to the new policy here in Tennessee, we are on a direct collision course with outdated MCO contracts. Current contracts still enforce inflexible compliance metrics. If a family makes an individualized decision to decline even a single vaccine, the MCO system automatically penalizes the pediatrician. To be clear, the issue before you today is not a debate over vaccines. It is a problem of math and basic economics. MCOs calculate a pediatrician's quality score using a rigid formula. For a typical tier 2 pediatric clinic, these quality bonuses account for 10 to 12% of their total gross revenue. Because overhead is largely fixed, losing that percentage off the top line effectively wipes out a clinic's entire operating margin. Missing these targets isn't just a penalty, it's financially devastating. The SHIELD Act provides a precise structural fix. It mandates that when a family makes individualized decisions, the MCO must remove the patient from the quality score denominator. This corrects the math, protects the clinic's operating margin, and keeps their doors open. This is a structurally sound solution, fully supported by the Tennessee Medical Association. We worked directly with TennCare on an amendment to streamline administration. They confirmed this works for them administratively, as MCOs can utilize their existing electronic claim codes to adjust calculations. This secured a clean fiscal review with no significant fiscal impact to the state. I know what's at stake here because for the past decade, I've worked inside the healthcare system specializing in population health. Today, my company partners with Medicaid MCOs to monitor patients, identify early changes in condition, and act swiftly to prevent costly ER and hospital admissions. In our line of work, ignoring a sudden change in condition guarantees severe complications. This federal policy shift is no different. It is a massive change in condition for our state's healthcare system. If we don't act swiftly to address these outdated contracts, our independent pediatricians will suffer an acute financial crisis, drastically reducing access to care. The SHIELD Act brings Tennessee into alignment with federal intent, protects the doctor-patient relationship, and ensures our pediatricians can keep their doors open. I respectfully ask for your favorable vote, and I'm here to answer any questions you may have.
Thank you for that explanation. Do we have any questions from the members? Seeing none, we will go back into session. We do that. Chairman Martin, you're recognized.
Yeah, just thank you, Madam Chair, again, and thank you for the testimony. I just want to make sure that this is just reasonable rules around patient-centered medical home models and that they don't unfairly weigh against the private practice of that individual. So the main thing that I'm after is making sure we get patients back into those clinics, those that might be ostracized or not going to see their primary pediatrician, that we can get them back in the door, allows those pediatricians an opportunity to communicate the importance of vaccine conversations as well. So that's, with that, I stand ready for question.
Thank you. Any questions for Representative Raper?
Thank you, Madam Chair. I move with the previous question.
Okay, the previous question has been called. Without objection, we are voting on House Bill 2243 as amended. Clerk, please open the vote. Has everyone voted? Does anyone wish to change their vote? Clerk, announce the vote.
Madam Chair, you have 6 ayes, 1 nay.
Thank you. The ayes have it. House Bill 2243 goes to insurance full.
Thank you, committee and chair.
Thank you. Item number 7 is House Bill 1061 by Chairman Vidal. We have a proper motion and second.
Thank you, Chair Lady, Committee. This bill.
Chairman Vidal, I do see that you have an amendment that rewrites the bill. We'll go ahead and get that on there, if you don't mind. Do I have a motion and second on the amendment? We have a proper motion and second. All those in favor of the amendment going on the bill signify by saying aye. Aye. Opposed? The ayes have it. The amendment is on the bill.
You have to say the amendment.
Oh, drafting code 13621.
That is correct.
Okay, thank you. Chairman, you're recognized on your bill as amended.
Thank you, Chair Lady. Committee, this bill simply eliminates no surprise billing with ambulance services. Emergency ambulance services are frontline healthcare providers required by law to respond to 911 calls regardless of a patient's ability to pay or insurance. Patients cannot choose their ambulance provider during an emergency, and providers cannot choose which insurance networks to join for 911 calls. Nearly 60% of the ambulance transports are out of network. You ask, what is balance billing? Balance billing occurs when emergency ambulance providers bill a patient for the difference between the provider's total charge and the amount charged by the patient's insurance plan. This typically happens in context with out-of-network status. And this bill is a comprehensive patient protection bill. It ends balance billing. It's fair and helps provide for prompt reimbursement, and it provides for oversight and enforcement through the Department of Commerce and Insurance. And with that, I'm open for questions and I appreciate your consideration.
Thank you for that explanation. Do we have any questions from our members? Seeing none, I think we are ready to vote on House Bill 1061 as amended. Clerk, please open the vote. Has everyone voted? Does anyone wish to change their vote? Clerk, please announce the vote.
Madam Chair, you have 7 ayes, 0 nays.
The bill passes. House Bill 1061 goes to insurance full.
Thank you, Chair Lady. Thank you, members, very much.
We are running out of time, so we are rolling all of the remaining bills to our next calendar. Do I have a motion to adjourn? We are adjourned.